Dr. Mohammed, you can see? Okay, and we will start the case. The COVID time, you know, many of the patients postponed the surgeries, and in some cases, the Malyugin cataract.
Okay, there is a voice, please. We need a voice for this one. Yalla, please. Hello.
Yeah. Yes. So
we need to hear the speakers.
You can see, but you can't hear me. Okay, this is the Malyugin
we
cataract.
can't hear you. I think Dr. Yuri, we cannot hear you because maybe you are mute. Can you just unmute yourself, please?
Okay, I will stop my video. I will stop my video. I can hear you and my sound is active. So, can you hear me? Dr. Mohammed? And now you can hear me? Dr. Mohammed, please reply. So this is the Malyugin case.
They are able to hear in the Zoom? Okay. Okay, can you connect here the voice to
capsule by Vision Blue, and you can see we just penetrate the central capsule and aspirate the soft material. And now the anterior capsule, make it visible. You can a strong fibrotic capsule and very small and hard nucleus. We try to create in central area the rexis, but there's zonal stress because the fibrotic capsule is not so easy to open. More mechanical traction. Finally, we reach the 6 millimeter rexis. And we start the case by the phaco. So before we open the capsule, we reestablish the capsule contour and inject the viscoelastic inside the capsular bag. A very small but very raw cataract. The patient, she has a surgery on the fellow eye 10 years ago. It was multifocal implants. We have all the calculation, but the patient preferred to wait 10 years before they come for this second surgery. So slowly we move to the end, and it looks like okay. There's no any problem. Clear cornea, the capsule. Now you can see the defect of the zonal. Without vitreal prolapse, we reestablish the capsule contour by viscoelastic. And put the capsule tension ring in the back. Both fragments out of the back in the anterior chamber, but it's important to put the capsule tension ring just to support the capsule fornix. So this is the bimanual technique. Just put the capsule tension ring in and continue the phaco. And this is the last piece. Yeah, slowly moving to the end, and suddenly the anterior chamber. This is not full collapse, but micro collapse, and attach the capsule. All parameters are not aggressive. This is a small piece. Now you can see the defect of the capsule, which is growing because the vitreous prolapsed. You can see very clear. So we keep the irrigation in and put the viscoelastic. This is the leakage and the vitreous also prolapse. So we put the viscoelastic, block this defect, remove the irrigation. So this is the situation. Put the vitreous back. And this is the linear defect. It's look like the round one, but it is linear. The vitreous is rounded, the rexis. So we should, before anterior vitrectomy, we should to perform primary posterior rexis to have elastic edge of the capsule. So try to enlarge a little bit this defect, but it's very important. If you want to put the lens in the back, and we have multifocal implants, so it should be in the back. So I try to remove the vitreous from the edge, and by the forceps, just enlarge the rexis. And at the same time, I try to avoid the traction, so I put the vitreous slightly back. Now it's okay. So we have a small fragment in anterior chamber. We have a vitreous prolapse, and we have a primary rexis, posterior and anterior one. So staining the vitreous with the lipospan to make it visible, and we start the anterior vitrectomy. So, but before the anterior vitrectomy, I decide to remove the pieces. I don't want to avoid the moving the small pieces to the vitreous. Enlarge the incision a little bit and try to remove this small piece. By the forceps. And this is the point for discussion, because some traction for sure we have. And in some cases, we try to perform anterior vitrectomy first before we remove this small piece. But in this case, I decide to remove it. Okay. Now we are ready for anterior vitrectomy. The cut rates is a maximum. This is a 4,000 cut rates. It's into the machine. With the very low aspiration and very low flow rate. We aspirate the small piece of the nucleus by the vitrectomy. And finally, we have the capsular bag for the implantation, and we save in the back implantation of the lens. We have chance to reach the proper position, especially for multifocal, it's very important. I remove the stitch, put the lens in. 10 years ago, the patient received a bifocal. This is a trifocal lens. The same material, but the design is a new design. So from Alcon, the Panoptics. And we have a very, very good result. For Morganian case, we not expect the high visual acuity because 10 years was the mature cataract. But the patient reached 20/20 for distance and 0.9 for near after 2 weeks. So this is the final how it look like. You can easily see the lens position is perfect. So thank you very much. And this is the first case. Thank you.
Thanks, Dr. Yuri. Unfortunately, we are running time, so otherwise we have a lot of questions for you. But we will keep it to the end, and I think that we can invite Dr. Boris Malyugin. He will give us his lecture about small pupil and cataract. Please, Dr. Boris.
Can you
The mic is with you
again, because I can't hear you very well.
Yeah, just stop sharing the screen, Dr. Yuri.
Yes.
Please stop it, and please, Dr. Boris, take the screen, sharing your screen, and start, please.
Thank you very much, Dr. Yuri. We will have you, inshallah, here. Then we'll discuss about this again. But because we are running behind the times, we'll take Dr. Boris Malyugin now.
Thank you.
Okay. I will now share my screen. And first of all, I want to thank the organizers for the kind invitation. And it's my pleasure to join you today and also to discuss with you the small pupil and cataract cases. I will have a few cases quite short. However, some general introduction is that the small pupil is not just a geometrical issue. This is because the small pupil is usually presents one of the symptoms that is showing us the other severe pathology of the eye, such as pseudoexfoliation and some others. And here is the devices that can be used for small pupil cataract surgery. There are different versions of them available on the market. This is the one that I'm a big fan of, which is called Malyugin Ring. Goes in different shapes and sizes, and having injector to be used. And one of the advantages is that actually gives you a very good fixation of the pupil in 8 points as opposed to the square shape of the device, and you may consider it square. However, 8-point fixation gives you a round pupil. And the surgical technique is basically in utilizing the injector, placing it at the very center of the anterior chamber, and injecting the device with 3 scrolls, one leading and 2 side scrolls, simultaneously catching the iris. And then you have to use your sideboard instrument in order to engage the last scroll. Sometimes you need to manipulate a little bit the ring to avoid having it in the incision, displacing it from the incision. The final steps of the procedure are as follows. So you disengage distal and proximal scrolls as shown here. And usually there is no need to disengage both lateral scrolls because they go out of the contact with the iris more or less simultaneously when you insert the device inside the injector tube. So this is an injector used to retract the device and place it inside the injector, and then this device will be removed. And don't forget to press on both lateral scrolls when you're removing the device, because when the incision is about 2.2 millimeters, it's more useful to have the ring fully retracted inside the injector. So these are the first publications made by David Chang on the use of the device in intraoperative floppy iris syndrome. And this is modeling made by David Lockington, showing that the device helps to avoid buckling and billowing of the iris, as shown here. This is the case of the IFIS without any pupil expansion device, and you will see here the red color representing the force on the iris, and when you stabilize it with the ring, so basically the bulging force may still happen. However, it happens in between the scrolls of the device, and it is not very significant, and that's why the pupil is not only expanded but also stabilized. So it's still possible to use the device in many difficult cases, such as in pediatric cataract surgery. So this is the child with cataract, bilateral cataract, and small pupil. And as you can see here, there is a need to expand the pupil more effectively in order to have a good access to the lens. Usually the lens is soft, and it's not a big issue to remove that. However, it's an issue of capsulotomy, as we all know, because in kids, the capsule is elastic, and you really need to have a good visualization of that capsule to avoid running that capsule out. And the second issue in kids is that with a very young age, the anterior chamber dimension might be small. That's why it's a good idea to use a smaller ring, which is 6 1/4 rather than 7 millimeter, in order to avoid excessive manipulation. So again, as soon as the ring is in place, I do like to start my capsulotomy with a sharp bent needle, followed by microcapsulorhexis forceps, as shown here. And there are many different capsulotomy techniques in pediatric cataract surgery being described. However, I think that the capsulotomy can be done with the CCC approach, curvilineous continuous capsulorhexis. And after that, the procedure becomes more or less routine, because it is easy to aspirate the lens contact from the iris, and then, as shown here, you disengage the device from the iris, followed by retraction it into the injector tube, and anterior vitrectomy is now being done to avoid visual axis, secondary visual axis opacification. And I always like to place sutures on the corneal wounds, because with the kids, I think it's a mandatory thing. Iris hooks or rings is a big controversy, because half of the surgical world is using hooks and the other half rings of various designs. However, there is a lot of evidence now that the pupil expansion rings are much easier to use. They require less operating time, do not require extra incisions, provide stable pupil during the surgery, and minimizes postoperative pupil deformity. And this is the publication made by Paul Urso and his team, showing that both in consultants and trainees, iris hooks took much longer time as opposed to the pupil expansion ring. And this was a very significant difference for about 10 minutes. So choosing in between two versions, first and the second, I think the classic version is having thicker and stiffer thread, is better to use in the very small and fibrotic pupils, while the second generation is indicated in moderately dilated pupils and intraoperative floppy iris syndrome. And it's a good saying about what is the best time to use the ring. And the conclusion is that the preventive approach is the way to go. If you think you need it, use it. And I think it's a very, very logical and useful approach. And I thank you very much for your kind attention.
Thank you, Dr. Boris. First, I'd like to thank you for this brilliant invention, the tool that made our life much easier in the OR setup, and made the small pupil not an issue anymore. Here, I only want to mention one thing, is that in the second hand, the hook that you are using is not just any regular Sinski hook. It's a special hook that comes with the ring. And if we put any other hook instead of this particular one, it's going to be messy, the process. But while using this, it's a very simple, fast, safe insertion and removal of the ring from inside the eye. Thank you.
Thank you, Dr. Hani. Now we will introduce my dear friend, Dr. Safwan Al-Bayati. He will give a talk about managing posterior capsular rupture after implanting a single-piece IOL. Dr. Safwan Al-Bayati, please.
Good afternoon, everybody. And I need to thank Dr. Mohammed Al-Amri for this opportunity. And I need to say hello to Dr. Yuri and Malyugin and Dr. Ashraf. They are hearing me, I think. And this session, basically, I will present management of posterior capsular rupture after implantation of one-piece lens. So it will be movie-based. Hopefully, the movie will be clear, and we will see that through it. So uneventful surgery, and it was, the astigmatism was less than 1, so I was correcting through the corneal relaxing incision in this session, because it's less than 1 using Varian. And pupil was a little bit small, but it was a fine surgery. I could proceed with the first line of dilatation, no need for any aids, and you can see that the pupil started to dilate. It's a very quick movie, so but we need to see all the issues, because the steps that in this surgery shows clearly where was the problem. Anterior capsulotomy in a good way, ventral central to the visual axis, and a hard brown cataract. Usually brown cataract, I'm having certain technique, so I will show you. An easy hydrosection with a rotation. I'm using an excavation in the center. So with this excavation, I can hold the lens and chopping the periphery to around 10 pieces or around 12 pieces according to the hardness of the nucleus. Now I'm doing chop. That was the first chop, second chop, and so on. All the peripheral parts. The pieces, the smallest, the better that I have. And it was very ventful. You can see there was nothing. Yeah, no, it's fine. Sorry. We will go just to correct, because we finally finished the nucleus with the lens matter. Nothing there was nothing. The capsule was intact. Usually I'm leaving viscotes, POVD, in when I'm leaving the anterior chamber. So till now, there's nothing. The capsule was intact fully. The bag was perfect. Polisher for the anterior capsule. And we implant the lens. The lens was having 4 eyelets from one of the company. I don't have any financial disclosure here. And here we can see now, with it, I start to have some upper side here. Here we are. Now we found that this is the line, and that line, very clear, appear in the upper part. And that shows a roll of the posterior capsule from the upper part. Now, the options that we have it, when we have such a things, it's either if we could maintain the posterior capsule, then keep the lens, then I can keep the one-piece lens, which is the hydrophobic. If we couldn't maintain the posterior capsule, then I will remove one-piece lens, cut it and remove it, replace it by two-piece lens with that I can put it in the sulcus, on the sulcus, and using the anterior capsular capture. If we lose the anterior capsule and the posterior capsule, then I will remove the lens and I will use a Yamani technique. But let us see what's happened here. So I found that the upper haptics is incarcerated in the rupture that happened superiorly. So I had to remove that haptics from the site. The chance of rupturing the whole capsule was very high here, but I have to do it. Otherwise, we cannot maintain it. So you can see now what we did. I tried to see the mobility of the lens. The lens is not movable, so I decide to take the superior part from the incarcerated, take the haptics from the incarcerated site. Yes. That was the main step to redirect our plan. I could do it. This is the first haptics, and then the second. So I rotate the lens. Now we are in the bag. Here, let us stop and discuss. We are in the bag. The whole bag, definitely the rupture was superiorly. The lens in the bag, the two haptics on 3 and 9, and we have incarcerated vitreous in the anterior chamber. So I decide to go through posteriorly, because if I will do any anterior vitrectomy here, I will opening the roll. I will create a rolling of the posterior capsule and it will open. So I will lose the stability of this lens. So that's why I decided to go posteriorly, and that's what I did. Posteriorly. Trocar, gauge 25, and I went and I directly did vitrectomy. Here I had one question that I present this presentation before. So the question was why you didn't put a decadron here in the anterior chamber. If we will put it while we are doing the posterior vitrectomy, we will obscure everything. Now, our aim here is to prevent rolling of this fold. This fold, it would roll back anteriorly because the vitreous coming through it to the anterior chamber. So we need to cut the vitreous from this side and clear that area, cutting the connection between the vitreous and the anterior chamber and the posterior chamber. And that's what we did. You can see this vitrectomy cut all the connection between the incarcerated vitreous in the anterior chamber and the posterior. It's coming to end. Now posterior triamcinolone to see what's remain, and the anterior triamcinolone. And we can see that there is incarcerated vitreous here, this area. Now I can remove it anteriorly easily because there's no connection between it and the posterior. And you can see, I went through the main incision and then I will go to the side. Now side incision vitrector, gauge 25. And I took it. We are on the safe. Here, this is the last. Again, just to clean the site, make sure that we don't have any remnant. Anteriorly, triamcinolone to make sure that there is no remnant of vitreous in the AC. We will remove the trocar, and that's the end. Great, thanks.
Thank you very much, Dr. Safwan. If there is any question, can we connect also with our speaker there, Dr. Ashraf and Dr.
Dr. Yuri and
Yuri, I
Malyugin.
think he will not be able. Dr. Hani, what if there is any question to Dr. Safwan before we have any question from others?
Do you have any explanation why this happened? Is it related to the haptic design of the lens?
No, I'm using this design of lens frequently. The issues is that if we can explain why, I think that it's because of the position of the 6 and 12. Now, usually I'm not keeping the lens on 6 and 12. Usually I'm rotating it and keeping it on 9 and 3.
Can we stop share your screen so they you can see the other speakers with us? Okay. Can you make the screen for the
because
others?
the stopping sharing that they need to do it.
Okay, please.
So I think that Hani, it's not because of the haptics. I'm frequently using this lens. The issues is that sometimes you don't know why you put it on the 6 and 12, and this is what happened. I think personally because I kept the lens on 6 and 12, and I usually I'm cleaning under the lens when I'm removing the viscoelastic from back, and I think that that's the steps where the one of the haptics goes incarcerated into the superior parts. The tailing haptics, both of them incarcerated into the superior part. But still with it, I could manage the rupture that's present there.
Dr. Safwan, could it be weak zone at that area, or there is or pressure, pushing the lens to the 6 o'clock, then it make a tears from the zenure itself?
I don't know what do you mean by the pressure, because usually when we are going under the lens, we are creating a pressure on the haptics, that's for sure. But the bag, it's with a stand. But in this case, we don't know, maybe the measurement of the the superior, inferior, and the temporal was different. The short superior in a way that it couldn't withstand the presence of this pressure.
I mean, here the cut is not in the capsule itself. It is from zenule, above the capsule.
No, it was in the equator.
In the equator, okay.
Yeah, it was exactly in the equator. When I dilate the lady after the surgery, after about 1 month, it was in the equator.
Okay. Okay, do we have any question, Dr. Okay, thank you, Dr. Safwan, very much. So we can have Dr. David Chang, his presentation. Unfortunately, Dr. David, he cannot do it, live, because the time now in US is midnight or even 3 o'clock. So we'll take it as registers and we will see. Okay, can you play this one, please? Thank you.
I'll be discussing strategies for removing the nucleus following posterior capsule rupture. I have no financial interest. Well, this is challenging because so often these cases have other problems. There could be vitreous prolapse, a small capsulotomy and pupil. We may have created multiple fragments, and of course the nucleus is ascending. So our goal may be to rescue and levitate and get that nucleus out while preserving as much residual posterior capsule for the lens fixation. So we'll start with this case of a very ultra-dense lens, and as I get to this last fragment over here, I point the phaco tip toward it, and all of a sudden you see the widening of this rent while I still have that large fragment there. So before I can withdraw the phaco tip, I have to, of course, fill the anterior chamber with viscoelastic. I have to recognize that this is the situation I'm dealing with, and I can't just aim the phaco tip and try to pluck that piece out. I have to try instead to prop it up and bring it forward, in this case above the iris, knowing that there's an opening in the capsule. And if I can levitate this forward and fill the anterior chamber with viscoelastic, that will support and freeze this fragment while I remove the vitreous so that it doesn't drop posteriorly. So I'm checking to see where if I have posterior or anterior capsular rim if possible. And now I'm going to do an anterior vitrectomy, but I'm using a pars plana approach, and I'm going to keep the vitrector behind the iris because I want to cut any strands that are moving from posterior to anterior chamber. So in this way, I'm not removing the viscoelastic that's holding and trapping that nuclear fragment up front. And then when I've cut this strand over here, now I know I can go back and safely try to phaco that piece without aspirating vitreous. Now to protect this from going further back, I'm going to use the 3-piece monofocal IOL as a scaffold, a technique popularized by M.R. Agarwal. I'm not sure I have posterior or anterior capsule on the left-hand side, so I'll leave the haptics protruding through the incision because I'm just not sure if there's support for the lens on the left-hand side. So now when I go back in with the phaco tip, of course, the IOL optic is going to block vitreous from coming toward the phaco tip. Very important. It's going to keep the little fragments that are created from dropping back. Now the lens is starting to shift over to the right hand side because of that trailing haptic. So I sort of have to carefully try to position this again as a floor to keep material from dropping posteriorly, and I was able to do that. Now we can open up the pupil. Before I wanted the pupil small because the iris was partly what was trapping the fragment anteriorly. But now we want to visualize exactly what is going on with the capsule, and we'll remove the residual cortex. Remember, we've done the vitrectomy. And here's one last little bit of vitrectomy to make sure there aren't any strands. And we can clearly see that the capsule orexis is fully intact. So now I can simply leave this 3-piece monofocal lens in the sulcus, and I'll try to capture the optic with the CCC so that it cannot rotate and it will be secure. I don't have to change the IOL power as a result. We'll close the sclerotomy eventually. There you see the captured optic. After removing the retractors and putting in Myocol to confirm there is no peaking of the pupil, we'll use an 8-0 proline suture to close the pars plana sclerotomy in that case. And we succeeded at not having to go after any retained nucleus at the end. Now here's a different case, a Flomax patient, and I've stopped because suddenly the pupil expanded and everything seemed to deepen in the anterior chamber. And I suspect there is this situation in the lower right of a posterior capsule rupture. So even though it's tempting to want to continue to phaco, I'm going to stop and I'm going to do a posterior assisted levitation technique. And I'm going to use the cannula, the viscoelastic in this case, and it's not completely blind because I know exactly where I'm pushing, and I'm simply trying to advance this entire lens into the anterior chamber so that, assuming I have a PC rupture, I'm not going to have this all descend posteriorly. So I've moved now to the superior location. I've abandoned my clear corneal temporal incision. I'm converting to a large incision because here I can't just continue phaco. It's much too large. So this is how we convert to a manual ECCE. I outline my incision at the limbus. I expand it, and I don't want to do bimanual expression here because I suspect there is a rent in the posterior capsule. So I'm going to put viscoelastic underneath and then in front of the nucleus to protect the endothelium. I go in with an irrigating lens loop. Now, if I encounter resistance, it's important not to press the nucleus against the cornea to squeeze it out. You really have to stop and go back and make the incision a little bit larger because we want this nucleus to slide out very easily. And I push a little bit on the posterior scleral lip. So again, I'm not pushing it and squeezing it against the endothelial surface. Now there's epinucleus left, but there's also presumably vitreous in here. So I'm going to move it around, but not try to burp it out. And this is a dispersive viscoelastic as shown in yellow in my diagram. It's viscoat. It will resist aspiration. And I'm using it here to trap the epinuclear material. Remember, as I do the vitrectomy, What's left to hold the epinuclear material? Nothing, because there's no posterior capsule. Now we're doing, again, through the pars plana and anterior vitrectomy, we're keeping the vitrector tip behind the pupil. That's still adequate to cut any bands that are moving from the vitreous space forward into the anterior chamber. And you can see that the lens material isn't moving. That's truly showing that it's been trapped in place with the dispersive viscoelastic. So I call this the viscoelastic trap. Now, once I've done the vitrectomy, I can go back to bimanual INA, or here I have my self-retaining infusion, so I use a second instrument to sort of mash the epinucleus into my aspirating port. And because I've done the vitrectomy, I know that I'm not going to aspirate any vitreous bands that are connected to the vitreous base. Here I'm through the pars plana again, last little bits of fragments that I'm trying again to sort of isolate with dispersive viscoelastic in the anterior chamber for removal. With a large incision like this, there's really no point in trying to suture a posterior chamber lens, because I can simply remove the iris retractors and slide in an anterior chamber lens. The eye is soft. We've been in here for a long time, and a well-sized anterior chamber IOL will do just fine. Again, with such a large incision, there's no real benefit to doing the gymnastics for a scleral, sutured, or fixated posterior chamber IOL. We will need to do a peripheral iridotomy. We see that Myocol not only constricts the pupil round, it confirms we don't have vitreous strands. I'm going to slide the anterior chamber lens over a sheets glide. We'll perform the peripheral iridectomy through the large incision. We're just making sure we don't have iris tuck from the haptics, and then we'll close this with multiple interrupted sutures. And again, we've converted to a manual extra cap. There again is the atovicral interrupted suture to close the pars plana sclerotomy. And we again succeeded at removing the nucleus safely in the course of doing both the anterior vitrectomy and the secondary lens. Now, it's important to, if you suspect a posterior capsule rupture, to not chase the nucleus, and don't be tempted to pluck it, because when you aim the phaco tip downward, as I'm doing here, the infusion is directed toward the rent. It will expand the rent, it will push the nucleus back, and if you happen to aspirate vitreous, you'll cause a giant retinal tear. Much better to leave the lens there, let a vitreoretinal surgeon clean it up, than to you yourself cause a retinal detachment. So this is something to do. Remember, if you're comfortable, it's an anterior vitrectomy. You don't ever want to aspirate vitreous with any instrument. Our goal is to clear the incision. You can leave the nucleus and let a vitreoretinal surgeon deal with it. Go ahead and implant any type of IOL, and always consider a timely referral to your vitreoretinal surgeon if you've had a complicated case. Thank you very much.
So now the turn of Dr. Ashraf with posterior, the turn of Dr. Ashraf with posterior lenticonus. Cataract with posterior lenticonus. Dr. Ashraf, you are with us?
Do you hear me? Do you hear me, Dr. Safwan?
Okay, Dr. Ashraf.
Do you hear me?
Yeah, we are hearing you, Dr. Ashraf.
Okay. First, I want to thank Dr. Mohammed Al-Amri and Dr. Safwan for the kind invitation. And
Dr. Ashraf, did you share your presentation? Yes. Okay.
Yes.
Now, we can hear you and we can see your presentation. Okay, go ahead, Dr. Ashraf.
Thank you so much. So I'm going to speak about some of the rare cases, posterior lenticonus. Maybe I saw it 4 times in my career now, just 4 times. It's a very one of the challenging situations. So I have no financial disclosure regarding my presentation, but these are my financial disclosures. So the patient data, it's a female infant, 8 months old, unilateral dense congenital posterior lenticonus, normal posterior segment parental consanguinity is positive, and the other eye is completely normal with a refraction +2 diopters. So I put a plan before any surgery. So you have to have the proper size and centration of the anterior capsular rhexis, careful removal of the epinucleus to prevent the early opening of the anterior vitreous face.
Just raise your
Slow
voice
motion.
or manipulate the volume of the sound, please. So I can hear you better. Yeah. No, you are mute now. We are not hearing you.
Can you please, hello?
Do you hear me? Dr. Safwan, do you hear me?
Yeah. Now we are hearing you.
Yeah. In this case, I started as usual. This is just an 8-month infant as a pediatric cataract with a straight cystotome. I do a small snip in the anterior capsule, which is highly elastic in this age group, to have a rim. And the most important in these cases, to fashion your anterior rhexis in a good size, not small and not large. And the most important, to be central. Because if you lose to put the IOL inside the bag, you are going to put it in the sulcus with an anterior capture. So take your time to do a good anterior rhexis, and always, as you always know, that in the pediatric cataract, you push to the center to have a good size of the rhexis. Another tip in these cases, it's already open, so don't remove the cortex directly with the IA, just from the periphery and leave it. Take from the periphery to the center and leave the center as it is. Don't go for removal of the all once. And this is the half side of the epinucleus, just remove from the periphery in the back and leave it in the center. Don't remove more than this. And after you remove the half, make sure that you don't go with the irrigation. Always maintain your pressure inside the anterior chamber, not to open the posterior chamber early, posterior capsule early. And we are going to do the other side also, just from the periphery to the center. And when you are sure that you remove all the cortex from the bag, at this time, you are going to remove it as one clump directly. And this will decrease opening of the anterior vitreous face. Make sure, again, don't go out, maintain your anterior chamber. With the cystotomy, we do a small snip at the edge of the posterior lenticonus. And with the viscodispersive, you are going to go behind the posterior capsule, injecting behind the posterior capsule a good size to separate the anterior vitreous face from the capsule. And from the edges of the posterior lenticonus, make from the side to the side. This is not a capsule. This is just a remnant of the capsule. It's like a fragment of the posterior capsule. All my cases like this, you don't have a complete posterior capsule, but when you remove it, you are going to find it is a very nice posterior rhexis was done. Like this. So the other tip, you should do an anterior vitrectomy to prevent post-operative increase in intraocular pressure. The fourth tip, you should inflate the 2 leaflets of the bag now, because you can implant single piece hydrophobic inside the bag. But before this, you should inflate the 2 leaflets perfectly. The fifth step, don't go directly to the back. You put it above the anterior capsule, and slowly with the haptic, you bring the haptic under the anterior capsule between the 2 leaflets of the bag. When you finish this side, mild rotation to bring the other haptic inside the bag between the 2 leaflets. At this point,
you put your anterior single piece hydrophobic inside the bag. And usually I take the suture to close in pediatric, as Boris said. And this is the time when I remove the sutures. You see how it's very nice, the anterior and the posterior. This is 4 months post-operative to the surgery. So my home message is, this is because of these conditions need timely proper management by an ophthalmologist. Early detection is mandatory, so the eyes do not suffer from vision deprivation leading to amblyopia and poor vision. Thank you so much.
Great, thanks, Dr. Ashraf. You hit two very important points in dealing with the posterior lenticonus. Now, posterior lenticonus, for someone that you don't know, that it's a herniation in the posterior capsule. But Ashraf highlight two important points when we are removing that capsule, is that using the viscoelastic the dispersive, when we are rupturing the site, one side, small site, and then we are pushing the dispersive.
Yes, it's a viscodispersive behind the posterior capsule.
The capsule and supported. So Ashraf highlighted in a beautiful way. I need to thank you, Ashraf, for that. And the second important issue is that when we have, or when we need to remove the part of the posterior capsule or recreating posterior capsulotomy for a reason or another, when we are implanting the lens, we need to implant it, as Ashraf said, because this is very important. We need to implant it in the anterior chamber and then pushing the posterior, the haptics slowly to the bag. Because if we are pushing that lens, as Ashraf highlighted in a very beautiful way, it will rupturing the posterior capsule. Great, thanks, Ashraf. I think that Hani, he need to mention something.
No, thank you, Ashraf, for this elegant surgery. It shows all of us how to address congenital cataract surgery in a very elegant way. I want to ask you, do you implant lens at any age in congenital cataract?
Yes, thank you, Hani, for your words. Yes, in my all my pediatric cataract, if it's unilateral cataract, I implant the lens in any time of the surgery. If it's bilateral, I don't do this. I wait till 2 years with glasses, then I start to implant the lenses in this age. But if it's unilateral cataract and the other eye is completely normal, I started to put the lens even in the first months of age, because when I examine the other eye and I feel there is no refractive error and the eyeball is with the normal axial lens for this age, this means it will not going to enlarge a lot. But if there is a difference between two eyes, as it is, if it's an isometropia, so you should consider the power you are putting. In this eye, in this patient, it is just 6 months and the other eye was +2. So I make this eye +2 at the other eye. So if it's going to enlarge, it's going to enlarge simultaneously.
Thank you.
I think thank you very much for all our speakers for cataract session. Thank you, Dr. Safwan, Dr. Hani, for being with us in moderating this session. And we are going to move to the next session. For those that are hearing us in the virtual, we have some problem, but they can follow us we will send either in YouTube or they can follow us also in link that we are going to share in our groups. Thank you very much. Bye-bye. And now we will move to pediatric sessions. And we'd like to invite Dr. Majdi Anis. He will be moderating this session. Dr. Ihab El Babli, he will be with him, and Dr. Hayat Khan. Okay, thank you. Majdi.